So first of all, understanding elder mistreatment. I want to start with a case presentation, in part because I think this group is probably familiar with this type of presentation. And I think it helps us to get a flavor for the kinds of things that we see when we're talking about elder mistreatment. This is a case that's based on a real story that was shared with me by my friend, colleague, and mentor, Alice Bonner. And it was a real case in Massachusetts, based on a real case in Massachusetts, that was brought to Adult Protective Services while Alice was the secretary of the Executive Office of Elder Affairs in Massachusetts, which oversees the Adult Protective Services among with other aging agencies. So in this case, it's an 83-year-old woman who goes to her primary care provider. She has a history of multiple chronic conditions, including Alzheimer's dementia. She has multiple medications, including that she receives a monthly vitamin B12 injection. She is independent in all of her activities of daily living, has no history of falls, but she does require assistance with instrumental activities of daily living. Her husband died 5 years ago, and since then she's lived with her youngest daughter. Her youngest daughter moved in soon after her husband passed. The primary care provider noted that she had some bruising on her left side and tenderness on palpation over that area. And then when they did x-rays, they found that there were fractures on 2 of her ribs. When initially asked by her primary care provider, what happened here, the patient stated that her daughter had pushed her. However, when asked again when the daughter was in the room, that story changed and she said that she didn't know what happened. The primary care provider recognized that that was concerning, and she made a report to Adult Protective Services through their online reporting system. Adult Protective Services opened an investigation. So Adult Protective Services role is, they screen a case in or out based on whether it's something that they can cover, or they think there's more to pursue there. So in this case, they said, yes, absolutely, we'll open the investigation, and a caseworker was assigned. When they started getting more involved, Adult Protective Services, they found that it wasn't just physical abuse, as indicated by the bruising and fractures, but possible financial exploitation was uncovered as well. The Protective Service Agency worked with the primary care provider, the patient, and the family, and helped the patient move into a safer living situation, which in this case was her sister. And her sister became the healthcare proxy and the power of attorney, and that case was closed. So ideally, of course, there's no elder mistreatment, and this never happens. But also, this case is a pretty ideal case. This was something that was recognized, reported, and Adult Protective Services was able to do something about it. We know that that's not always the case, that oftentimes things are more complicated. There are not these direct physical abuse signs, that they're more subtle. And it's not always the case that Adult Protective Services is going to be able to come in and do something and make the patient safer. We're going to talk a little bit today about some of the more nuanced cases, some of the things that clinicians can do to recognize them, what happens if you make a report and you feel nothing happens, what other kind of avenues for response might you take. But first, I want to hear a little bit from you all about your experiences identifying and responding to elder mistreatment. So if you don't mind participating a little bit in this activity, could you please raise your hand if you, in your practice, have had concerns about elder mistreatment among your patients? Wow. I expected a lot, but that's nearly every hand in this room has gone up. So, wow. And then how about raise your hand or keep it up if you filed a report with Adult Protective Services? Wow. And how about, and I don't have this on the screen, but raise your hand if you've been satisfied with the response when you've made a report to Adult Protective Services. A few less. We're going to talk about that. Okay. So before we get into that, I did a little recon before I came to GAPNA, and I heard that there's kind of a range and level of experience among the nurses in this room. And so I do want to step back a little bit and provide some definitions for those of you who may not be as familiar with this topic. One important thing to note is that with elder mistreatment, currently, the definitions of what constitutes elder mistreatment and what's covered by Adult Protective Services, for example, varies widely by state. So what I've done here is I've picked some generic enough definitions from national organizations that I think we can use to agree for today to kind of define elder mistreatment. But it is important, and I'll mention this again, to understand what the definitions that are covered by Adult Protective Services are in your own state. So for elder abuse, generally, we think about intentional actions that cause harm or create a serious risk of harm to a vulnerable elder by a caregiver or another person in a trust relationship. So this is different than a random act of crime committed to an older person. Neglect being the failure of a caregiver to fulfill their obligations, which results in harm or distress to the elder. And then self-neglect, which is very complicated, but a general definition here is a situation in which an older person is unable or unwilling to provide their own basic needs, such as personal hygiene, nutrition, hydration, medical care, or safety, to the extent that it threatens their own health and well-being. A little bit about prevalence, and actually I was going to say, this might be surprising to you to learn that 1 in 10 older adults, community residing, and cognitively intact older adults are affected by mistreatment. Now that I saw how many hands went up in the room around having recognized it, I'm not sure that that's going to be a surprising statistic to you all, actually. But actually, it's really underreported. So we also know that only 1 in 24, which works out to be about 4% of cases, are actually reported to appropriate authorities, that being Adult Protective Services or law enforcement, in some cases departments of health. And we also know that the aging population is growing rapidly. And so if these numbers stay the same, by 2030, we're going to see 7.3 million community residing, cognitively intact older adults being affected by elder mistreatment, and 7 million of those going unreported. So this is a very important topic, and I'll tell you more about why the consequences need to be addressed. When we think about prevalence, so the 1 in 10 is one of those numbers that's cited a lot of places and put in a lot of infographics like I did here. But when you think more about the context, you learn that there's variation in those prevalence rates depending on where that older person is and what other kind of chronic conditions they're experiencing. So that 10%, as I said, that's community residing, cognitively intact. There's a study that was published in 2019 that found that 64% of nursing home staff admitted to elder mistreatment in the past year. That's a really large number. We also see that when you look more closely at older adults who have dementia, the rates are much higher. 50%, we see rates up to 50% of people living with dementia experiencing some form of elder mistreatment. A little bit more about kind of the types of elder mistreatment. We see that financial exploitation and neglect are among the most common, with emotional abuse not far behind at 4.6%, and then physical abuse and sexual abuse less prevalent. I don't think that's terribly surprising, but what is important to recognize, as demonstrated in the case that I shared at the start of the presentation, is that these types of elder mistreatment often travel together, that it's not usually just physical abuse by itself, for example, or neglect by itself. There's often multiple types of abuse or mistreatment happening at the same time. Bless you. So what are the consequences of elder mistreatment? So why do we care about this? What happens if somebody's mistreated? For one, there's devastating health and social consequences for people who experience mistreatment. Some of these may seem obvious, and others may be not as obvious. For example, it seems to make sense that someone who is being abused would experience emotional pain, that they'd feel helpless and fearful, that they'd experience increased stress and depression symptoms. But it might be a little more surprising to learn that elder mistreatment is associated with a 300% increase in risk of death. And that's controlling for other chronic conditions. We also see increased dependence and loss of physical and cognitive abilities with elder mistreatment. And social isolation, which is a hot topic right now in the field, and a very important one. It's both a consequence and a risk factor for elder mistreatment. I think it's a pretty well-known tactic among abusers to isolate the person that they're abusing so that people are less likely to recognize it and things. Great. Okay. So next up, in addition to the health and social consequences of elder mistreatment, we also see devastating financial costs. In the healthcare system, we see that elder mistreatment results in an estimated $5.3 billion, that's billion with a B, in healthcare expenditures every year.